Hi, this is Dr. Sanjaya. Emergency departments are big, bright and buzzing parts of a hospital. It is an environment that my latest behind-the-curtain guest, Dr. Alison Lally, knows very well, having worked in emergency medicine in the United States and now in Canberra. Alison is a strong advocate for neurodivergent patients, and she spoke about the strategies and tools she and her colleagues use to support these patients in the ED. Let's jump into our chat. Welcome to today's Behind the Curtain podcast. We have another very special guest from Canberra Health Services. Gracing us with her presence is Dr. Alison Lally, who is an emergency physician and Deputy Director of the Emergency Department at Canberra Hospital. Welcome, Alison.
Thank you for having me. I'm very excited to be here.
Oh, look, no problem. Alison, we did talk about this. You can't be called Ali, and can you explain the reason why?
Because there's another Ali in the department who took the name first, and it suits her really well. So she's Ali at work and I'm Ali at home.
Okay. Look, so potential tension there, but sorted out.
No tension at all.
Oh, really?
Yeah,
you want to make it exciting for the podcast.
No.
Okay.
We've got lots of Alisons and Alis in the department, so it's an awesome name.
Okay, wonderful. So, Alison, you're an emergency physician. You obviously decided to take that at some point in your medical career. Where did you do medicine?
I actually did medicine here at ANU. I was one of the third year through, so it was all very new, very, very new, and it's almost a bit of nostalgia now when you see all these new medical students starting at ANU. So that was many years ago, and I finished my training here. I did intern and resident year here, and then halfway through my SRMO, or third year out, I went to America and worked as an emergency physician there in a residency program. And then really there was a turning point when I was over there where I just realised I want to come back to Australia, and that was there were a few massacres that happened, not to turn all doom and gloom straight away, but it was a major trauma, saw lots of gunshot wounds. We're in Western Massachusetts.
Right.
And I just reached a stage where I was just like, no, I can't do this anymore. I can't think about having family or having my further life here. So I did make that tough decision to leave a residency program early, which I know a lot of people kind of go, why? But it was more for a life reason. I came back and worked in Brisbane for a number of years, continued my training there, and then life had it that I came back to Canberra. I reached out to the team here and said, will you have me back? And they said yes. So I finished my training here, and I've been a consultant now for 4 years.
Yeah, look, obviously you've mentioned the gunshot trauma in the US. Apart from that, was it very different working in the US?
It was very different. It was really different. Their residency is much shorter, but really long hours. I think the Australian way is much better, and not just because I'm Australian and I've done the Australian way, but I think that there's no such thing as wasted clinical years in your training. And so for anyone who's in the middle of their training and they think they've done a year or two wasted as, for example, unaccredited registrar or moving somewhere else because they don't know what they want to do, I think every year you learn so much. And that's a great thing about emergency or just medicine in general. So I did take a lot longer to get through my training than others, but it was a really good experience. They're also, at that time, a lot more progressive than us here in Australia. So it was pretty amazing where I fell in love with the ultrasound. They were really passionate about ultrasound back in 2012, and I feel like we're really lagging behind on that. We had electronic medical records over there were so well integrated, and that was 12 years ago. I can imagine we introduced that about 18 months ago. So some of it was amazing. Some of it certainly is a different relationship than what we're used to here in Australia. I found it more a lot of over-investigating, a lot of admissions, and at times down the track, I think it might be at the risk of the patient probably getting over-investigated, and the role of that about admitting everyone. They're not appropriate for all patients to be admitted to the hospital.
And I think part of that over-investigation is related to the whole medico-legal background there, isn't it?
Yes. And there is a lot of medical-legal things, so they really have no risk stratify, I guess. And here we do a lot more of our risk stratifying, not over-investigating and CT scanning everyone, because that down the track has really adverse outcomes to the patient. So very different. They got very good at documenting over there. And it was a really great experience, really wonderful doctors over there, wonderful patients. And I just thought it was such a diverse patient population there, because there were a lot of poor people in the state of Massachusetts at that time. It was the Romney Care, so everyone got cover. So we saw everyone.
Yep.
No one was not treated based on their health insurance, which was really good. So I didn't see that other side of America. But the medicine and the teaching, very structured training programs, but very short. And I think that we've got a good balance here. You get a bit of everything first.
Yeah, my understanding of the US system is that you finish medical school and you sort of have to decide then and there, I'm going to be a surgeon or a emergency physician or a dermatologist or whatever, and you just enter a training program, and after a relatively short training program, you're it. And I do agree with you. I think having that more holistic experience, doing some weeks in some months in emergency on a medical term, on a surgical term, just helps.
I definitely think the first 2 years is really important. You become a more grounded doctor because you've got more experience. You also know how other things work. So it gives you that insight as to what it's like on the ward. You're not going straight into emergency. And it is only 3 years. And so one of the other downsides about emergency over there is that the physicians or the attendings, consultants, what we call here, do nights when they're done. And so I don't really see much of the motivation to finish your training over there because there's always nights. So they have a really tough roster there, but they've had a mass exodus from emergency medicine in America recently, and I think a lot of it's been the result of the impact of COVID lockdown. They had it really tough over there. We were quite protected here when hearing stories about some of the people I worked with, what they went through. So I hope that there are some people that can find their passion in emergency medicine over there again, because it is a great specialty.
No, exactly. And now you mentioned you were one of the early cohorts to the ANU, and in fact one of our infectious diseases physicians, she was in that first year. So the medical school's really thriving, which is wonderful to see. Did you come from another place to go to the ANU, or were you based in Canberra to start?
So I came from Sydney, and because I come from a big family, there's 5 siblings, which I know is almost unheard of these days. I made the decision to move away because I just didn't want to live at home. I think you have a much better experience and immerse yourself into the culture, and also just focus with all these people who you go through this amazing journey with. So I moved to Canberra. There's amazing cafes, there's heaps of breweries, there's a lot more here than what there was back in the day.
I can tell you, hearing this from younger people, that people at universities in Sydney say that Canberra, or the ANU, is the party university, and maybe because of that college culture as well. So I think it's a lot of fun.
There's a few of us who are still here, and it's amazing how so many years down the track we just formed such great friendships there, and that now you run into each other. It's like no time has passed at all. And I think the smaller classes here is amazing as well, and it's really good for that ongoing support that you have.
And what do you think now, if you're a young doctor and thinking about a critical care pathway like emergency, Canberra a good place to train?
Well, Canberra's an amazing place, and I guess the reason why I'm saying that is I did do part of my training up in Brisbane, and you got to go to all different sites and travel lots of different places, and there is traffic and stuff in the bigger cities.
Right, sorry, and what's this traffic thing you talk about? What is?
I know, there are people that are actually okay driving like an hour to work and sit in traffic and only go 5Ks. It's bonkers. I know. I guess you get to fit in some good podcasts, but when you're trying to juggle work and home life, I think traffic's just something that you don't have time for.
Oh no, and I think if you haven't experienced a 10-minute unencumbered drive to work, you probably will put up with the 1 hour, 5 kilometre drive in traffic.
And just before we left Brisbane, it did start to get really bad, where it was like, actually, this is not doable with a growing family. So with regards to Canberra, we've just opened up this new emergency department. So that's been pretty busy for us over the past few months preparing for that. And we moved into it 3 weeks ago. And so for a new trainee coming to a brand new department is really exciting. We have expanded and we've got good capacity to grow into our department over the next 40 years. And it's massive. You get to do your foot count during a shift. But we have major trauma. We see really unwell kids, unfortunately. We have a lot of subspecialty services here, both neurosurgical, vascular. We are the catchment area for all of southeast New South Wales. So from an emergency perspective, you're going to see everything that you need to see in your training. You can actually do all your training here in Canberra Health Services, which includes the peripheral side of North Canberra Hospital. Well, not peripheral, but that's what's great. One of your peripheral site hospitals is, 15, 20 minutes away. We have a really good critical care stream here. So I'd recommend most people to do 2 years of general intern resident and then really start to focus during your resident year going into a critical care year, because not only most people want to just start their training straight away, but you actually get to work with other colleagues who you're going to work with for the next 15, 20 years of your career, where they go into ICU, anaesthetics. Some of our critical care streams do have cardiology as well. So it's really good to go and do that term. So you experience that for a year and then go into your registrar training.
And we had another critical care pathway consultant, Sean Chan, from intensive care. He was speaking to us recently, and Sean was telling us about why he veered away from emergency towards intensive care. Now, what about you? I'm sure, as you say, when you're introduced to those different pathways, ICU, anaesthetics, emergency, you have to choose one. What made you go down the emergency path?
Well, I actually wanted to do emergency when I got into medical school. So I was one of those people who really wanted to do it. I did get pulled in different ways. I really liked orthopedics and O&G, and then I just came back to emergency because it's a bit of everything. The things I love about emergency is you're always working in a team. Having that ability to really have an impact on someone who's having usually their worst day, to be able to have that impact and help them. And it might only be something really simple to us, such as give them pain relief or to explain something that someone hasn't had the time to explain about. For example, pneumonia. You're actually going to feel lousy for more than just a few days. It's a few weeks to months recovery. Or you're going to have a cough for a while. You don't need antibiotics. And it's just sometimes just explaining things, or an anxious first-time parent who's really worried about a fever, and explaining that to them. So there's also all the stuff from the TV show ER that totally inspired me to do emergency medicine. I loved it. Yeah. So real as well. Especially when I was working in the States in the old hospital. Then we moved to a new one while I was over there. But it was very much, I was like, oh my God, it's so real in the scrubs. There's all parts of emergency, but I also think we have this ability to really help people at a crisis. And I think that's one part that a lot of us do really well, even though it might not seem like we're doing a lot, but a lot of people go, well, just thank you. Thank you for taking the time. Thank you for explaining it to me.
Yeah. Other thing I also tell junior doctors who are thinking about a career, I always say, look at not just what interests you, just look at the doctors working in that area, and are they sort of similar to you in their outlook, their personality, and generally if you've got the interest and the other people are a bit like you, then it probably is a reasonable chance that that's the right one for you.
Yeah, and I also tell juniors, no matter what you do, you've got to be happy doing relatively the same things for the next 20 years of your career, so to speak.
20 years? Look, these days are probably about 40 years or something, isn't it?
I don't know, some people might branch off and do other things or do early retirement. I don't know. But, by the time you finish with your training, usually training takes anywhere between 5 to 10 years, depending on life, depending what happens with life. But you just got to be happy doing it. So you're happy doing the same thing. If you want to go into ICU, you're happy dealing with that sort of environment for the next 20 years. You're happy dealing with orthopedics, doing your hip replacements all the time, so no matter what career you go down, make sure you think you're going to be happy doing it. And also, how happy are the bosses? I think that's a really big thing, is that if your bosses are happy and enjoying work, then that's a really good example of a supportive department, a really good place to work. And I think on the whole, most of us on a day-to-day good, sometimes we all have our bad moments where we're just exhausted, or the patients don't stop coming, but on the whole, we're all really a good team and everyone's really happy in their jobs. And, so I think it's a good sign that emergency here is really good.
Alison, you've got an interest, as we all get interests as we go into a speciality. Yours is in the area of neurodivergence.
Yep.
And I will tell you that I do not know much about this area. My first introduction to this area would have been Rain Man back in 1988. I was a school kid, and Dustin Hoffman, the acted very well, the goofy brother, socially awkward, mathematically brilliant individual. That was my first exposure to someone with autism. And since then, I've had the terms Asperger's syndrome, autism, neurodivergent, on the spectrum, all these different terms being bandied around for what is probably the same thing. But just with those terms, for instance, do you mind breaking it down and telling us what's correct, what's not, and what's old and what's new? And
Yeah, so I guess a little bit about how I'm here. I was very similar to you, although I'm a little bit younger than you, so I don't remember Rayman coming out.
a lot younger than me,
but Rayman is very commonly quoted regarding what's it like to be autistic or dealing with someone who's autistic. And certainly there's the scene with him really wanting to go to Melbourne at the airport. That is our son all the time. So I'll be honest, at medical school and life in general, I just thought autism, or what we were taught was autism, was a boy who's usually non-verbal and just sits in a corner and doesn't do anything. And we're told it's a developmental issue and that's about it. And really, I learnt about this when I was sitting my fellowship exam. So when we finish our exams, we have that really stressful year where everyone around us walks on eggshells because we're trying to balance everything. We just moved from Brisbane and my son just started regressing. He just stopped really talking, not engaging, and just acting a bit different. And we had a 1 week old at the same time of moving down. So we were that was all happening with the transition and change. Then I went back to work, started focusing on my exam, and it was when he went to preschool that they just said, look, something's not right. My husband and I thought something, but I remember looking up something going, does he flap his hands? Does he just stare in the distance? Remember we did a little checklist, like maybe he's autistic, but he doesn't meet any of this. Like, sure, he's a little quiet at times. He sometimes looks in our eyes and sometimes doesn't. So maybe it's just an adjustment issue. We'll just keep going. And then I remember the school sat me down after doing a day of study and said, look, we just think there might be something wrong with your son. You probably need to go see someone.
Yes.
At this stage, I reached out to one of the local paediatricians and just, said, is there any way we could just start having a catch-up? And she approached it really well, that we just had regular check-ins every 4 or 5 months.
Yep.
Just to progress and see. And I've got to say, she did it in a really good way. I think she could see that I was probably feeling a bit stressed. We then started getting an OT and started getting a speech path. And then I had my follow-up appointment with the paediatrician the day I found out I passed my exam. So I was so elated, and then went to this appointment and she sat me down and she goes, I think Alex is autistic and we need to get him assessed by a psychologist. And I remember just breaking down. I was just so excited. And then I felt really bad that I put all this stuff on hold. Did it change anything? It really didn't change anything to where we are now, but my learning curve was massive, and I probably had bandwidth to start learning about it because I'd finished all my exams. Does that make sense? And I think if I was to have it, I think she just was really good and got that parental stress and that parental life of what's going on, like when is she ready to deal with this? So I learned a lot. So I started reading everything, as I'm sure most parents do. Yeah. So this then started kind of a journey where I started to advocate for my son, because there were a few things that probably didn't fit. He didn't fit very well into the school system he was in. And so not only have I started to learn more about how we can do more in the medical area, but also how parents can advocate for their kids in that schooling education, which is really important.
Yep.
I then realised once I had probably time to exhale, compound everything that I kind of learnt from all these different podcasts and books and webinars, I then was like, actually, we need to do better in the ED. This is the most chaotic, unpredictable environment ever, and we need to do more, because even though autism is rising, or the diagnosis of ASD, autism spectrum disorder, is rising, we don't actually see that many kids in the ED. And the latest stats was 1 in 70 kids. We would see, many kids a day. In the course of a month, sometimes it's 2,500 kids. We don't see that many.
And when you say 1 in 70, do you mean 1 in 70 kids visiting an emergency department, or 1 in 70 kids having autism?
Oh, having autism. So
It's
increased, and part of that is for a few reasons, which I'll get to in a minute. But I was like, we're not seeing them in the ED, and the reason why is because when I've had to bring my child to the ED, when I had to bring Alex, it was really traumatic.
And you work in the
and I
ED.
work here, and I was like, imagine those who don't work, because a lot of autistic kids like to know what's happening. They want to know so they can expect. Anything thrown onto them causes a lot of stress and anxiety, and they act out or they just don't want to go. And so I had that experience, and then that triggered me to actually, I need to start educating. I need to start looking at how we can improve a space for them, and also how we can get some tools. And so I guess I'll just park that for a second and just talk a bit about autism spectrum disorder.
Yeah, sure.
Because there was a lot of questions there. Neurodivergent is really something that's come out just recently. When I was doing all my reading 5 years ago, it was more talking about typical and atypical. And there was a really good, or neurotypical, neuroatypical. And at that stage, there was a really good show on Netflix called Atypical, and it was about a teenage boy who was autistic and loves penguins, and my boy loves penguin. And it's so good. Like, they've done it in such a good way, and it's kind of sad that it stopped. But they did actually have, although the main character wasn't autistic, they did actually have a lot of autistic characters in the show. And that was just kind of good as an introduction to tell people, why don't you watch this show? It just gives a bit of idea about what it's like to be autistic. When we talk about, I'm going to say I'm not an expert, but there's things about, we don't say someone is autism or has autism, we say they are autistic. It's a way of them being. I'm still learning person first, or their identity first. All those sorts of things are still really, I'm still learning. So I'm not an expert in regarding the terminology. But neurodivergence, really, I like to think of it as all those people who are differently wired. And I took that term from, as I said, I've done a lot of reading and listening to audiobooks, where it's those kids that are just wired differently. And that includes people who've got ADHD, which is also another really common diagnosis now. People who've got ODD, or oppositional defiant disorder, people who've got twice exceptional. So there's all these things where people are just really, they just function a different way.
Yeah.
And the way I like to think it is, we are expecting people like Dustin Hoffman in Rain Man to live in our world, which at times is really overwhelming, yet we don't go live in their world. And if we want to go live in their world, they're seen as odd or different. And because they're not fitting our social norms, that's why they get that's why it's so obvious that someone is neurodivergent. They did get rid of, in 2012 or 2013, the DSM-V classifications changed, and that removed Asperger's. And it started to bring in levels, so ASD level 1, 2 and 3. And usually the levels are based on the amount of need that is required, or additional support or assistance, or how well, their challenges in functioning in our world. And so my son is ASD level 2, so he has a lot of social issues, language issues. And as a result of that, he has a lot of regulation issues as well. So
that progression, I guess, with all these subcategories in the DSM, does suggest that hopefully we're trying to we're better at understanding it than we were before.
I mean, I think Gen Z are just so accepting of different people. They are so accepting. When we think about all these different, the way life has turned, we've got so much more acceptance of things like being gender fluid, things like, being neurodivergent, understanding that people learn different ways. I think this generation is absolutely amazing. And it's relevant when I think about, I'm considered a millennial. I didn't know anything about it. And now, I get some girls to help me with my kids. Yeah. They're all like, oh yeah, I know heaps of autistic people. And it's just so different. And they're just so open and accepting, and nothing phases them. And I think this generation, we can learn a lot from them with regards to that, because it's just like nothing phases them, and it's great. So there is a lot more neurodivergent diagnoses out there. And I think part of it was when the diagnosis changed in 2012, the criteria changed, which meant there were more people getting diagnosed because there was changes and increased awareness. There's so much more awareness of it now.
So a sort of surveillance artifact almost.
Yeah. Because there was always that odd person, what we would say odd, or the socially awkward person, or someone who really struggled, but when there was maths, think of a brilliant mind where he's able to communicate all in his equations. Like they've always been around, but it's just more the awareness.
Exactly. And now coming back to the emergency department and the toolkit.
Yep. So regarding how we can improve things in the emergency department, it did start with education. So educating the staff, what is it to be neurodivergent? What's with all these new terms? How do we approach people who are... I've probably got more experience with autistic patients or autistic individuals because of all the reading I've done, but a lot of the strategies are much the same. So I spoke about what are things that don't really cost anything, and that's simple things like dimming lights, turning off monitors that aren't needed, as minimal staff that's clinically safe. So if you have 10 people walking around coming in and out that's not really needed, only one is fine, then that's going to actually help reduce the stress and anxiety. Also explaining what's happening, which we could do a lot better in this space. A lot of the times we just go, we're going to do a cannula and just pop it in without actually explaining, it's going to be cold, it's going to feel tight. All those steps, it actually doesn't take a lot for us to explain. So trying to explain those things and where possible, giving the patient some choice. Would you like this sticker or this sticker? We know they need a sticker, for example, but in which way? So a lot of it was education. Then there was a few tools and strategies. So it started with a few of us getting some things and donating it to the department. Really simple things. One is if we just dim the lights and use a light projector where you put blue light and the stars. You dim a light, put that on and do some nitrous, for example, which is like a laughing gas. That just really calms a child getting a cannula, right. Or even just dimming the lights and blowing some bubbles. It's really simple stuff, but with the chaos and the busyness of ED, sometimes we don't stop to do this. The few other things we have are things that reduce stimuli. And so we are sitting here now, and for some people, the bright lights might really impact them and they might hear a noise that you and I can't hear. So in order to reduce that really overwhelming stimulus, we have headphones, not fancy Bluetooth ones, just very simple earmuffs.
Sure.
And sunglasses if they need that reduction of that overstimulus. So they can just focus on other things. So something simple like that, which unless you've done some reading into this and some understanding, you wouldn't think much about it. And so it's trying to relay a message that's really easy to understand and we can pass on to staff quite frequently. We got some money from the foundation, which I'm very thankful for. And they gave us funding.
Which foundation?
The Canberra Hospital Foundation.
Yep, okay.
Which we're so thankful for.
Yes.
And we got Smiley Scopes, which are virtual reality goggles. And that actually, because I was really trying to see how we could help these neurodivergent patients, they did do a study on how it actually helps autistic people getting vaccinations, and it showed that it actually improved their experience with getting vaccinations. So use that as part of our, building a case.
What are these?
They're virtual reality goggles. So you put them on and you pick, one thing might be just a distraction technique regarding getting a cannula. The other one might be a relaxation, so doing some meditation with them, talking them through that. Another one, which I really quite like, is called Relax, and you can put it on and it's a video of all the puppies, the guide puppies, and you can look around and see all the puppies. So it's really cool, and it's been game changer. We also use that for kids who've needle phobia, but also just kids in general to reduce the distress that comes from doing procedures. And with our sensory trolley, we've got a few other things that help with particular senses that help neurodivergent kids or patients relax. So some people, without realising it, all of us do things without realising it when we're stressed. So if you think about people who bite their nails, people who click a pen, people who constantly put stuff in their mouth, people who tap their feet, we are all doing things, and this is a way of regulation. And there's been a lot of work done into this to see that some people have what we call sensory profile. And some of this stuff I don't even quite understand. I had to get my head around it. But it's that I'm an oral seeking person to help reduce my stress. So if we think about all the times we're stressed and we have chocolate, for example, we're sensory seeking, oral sensory seeking. So I've got a few devices that help with that. So one's very simple, like pinwheels, a lollipop, blowing up a balloon, all these things that help with your oral. The other thing is visual. So a lot of people get fixated on things. So we've got some things that help with the visual. So, there's little games where you have a ball going around, you try to get it into the hole. Another one is the water game where you press a button and the ball goes to try to get into the hoop. We have stress balls. So just that being able to stretch it. squish it all the time. And another really easy one, which doesn't even cost a lot, is just Play-Doh, for them to be able to play with Play-Doh, roll it, whichever way they want. We put this together based on what the sensory needs are of the child. We do have some of these things in place with our staff, just those simple things like turn off monitors, as I said, reduce the lights. Those things, really simple things, we can really implement for all our patients when it's clinically safe to do so. And so that's what we really want to do. But these other strategies will help, in particular the kids that don't quite know how to regulate themselves.
And Alison, is this something you would find in other major emergency departments in Australia? Or is this very much something that we've come up with in Canberra?
So I want to say the one thing we have come up in Canberra is our sensory room in our children's emergency department.
Oh yeah, tell me about that.
Which is really exciting. I think it's so exciting. So it's a space in our children's emergency department that is a space for kids to essentially regulate and to prevent them from reaching a stage of a meltdown. So autistic kids or neurodivergent kids who are starting to feel really anxious and stressed out, if we can start to see it by them pacing or starting to become a bit, we can put them into this space, and it's essentially devoid of a lot of stimulus. So it's dimmable lights, can't really hear much in the way of sound. It's quite bare when you first walk in there, because the point is that it's a bare place that we then add things to. So there's a beanbag and benches. We do have the funding approved for an interactive software so that kids can think they're underwater and press the fish, which is really exciting.
Yeah, sure.
But we do have these other tools. So if someone really needs to just, essentially just use their smiley scope with nothing else around, we can put that there, or an iPad with a game or something. We had a kid the other day just wanted to rip up paper in there, and that was his regulation strategy. So it's a place that we're building that rapport with the patient and the parent. We're advocating for a child to have an experience that's not so overwhelming, because otherwise they're less likely to seek healthcare later on in their life. So we're hoping they have a positive experience now, so down the track it's not so overwhelming for them.
Alison, that's a wonderful innovation, and it's been an absolute pleasure talking to you, hearing about your journey from Massachusetts, Brisbane, back to Canberra, and all the great things you're doing, particularly with regard to the autistic spectrum disorder in emergency.
Thank you.
My pleasure, and hopefully we can have you back one day.
Hopefully, anytime.
Thank you for listening. I hope you'll join us behind the curtain for our next episode, where we'll delve into the story of another of our fantastic health professionals here at Canberra Health Services. If you're interested in starting an exciting career with us, head to our website to join Team CHS. And that website is www.canberrahealthservices.act.gov.au/careers, CAREERS. I acknowledge the Ngunnawal people as traditional custodians of the ACT, the land I'm recording on, and recognise any other people or families with connection to the lands of the ACT and region.